Hi everyone, welcome to our first education session for 2024. I'm Jo Silver, I'm the GP advisor at Western Health, and our session tonight is on the Western Health Integrated Pain Service, a new model of care for the West. Thanks, Olivia. Next slide. So I'll begin this session by doing the acknowledgement of country. So Northwest Melbourne Primary Health Network and Western Health would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woiwurrung people, the Boon Wurrung people and the Wathaurong people. We pay respects to elders past, present and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. So we'll just start as usual with a little bit of housekeeping. So I don't need to tell you where your toilets are because you'll all know that. So everybody is muted so as we don't get so much background noise. If you could ask your, put the questions in the Q&A box only, try not to put them in the chat because I can't cope with jumping backwards and forwards. The session tonight is being recorded, so you will receive a link to the recording as well as a copy of the slides in the post-session correspondence. So that is really helpful. You don't need to worry about sort of taking screenshots and taking copious notes because the slides will allow you to review the session. So the other thing is if you could just make sure that you've joined with the name that you've registered with. If you haven't and you're on one of your kids' laptops and you've got some funny name, just put a message in the chat box to Olivia, who's our tech support from the PHN tonight. And Olivia will if you can put your name down and she'll make sure she marks you off for attendance and your CPD credentialing. So we are really lucky tonight to have three great speakers from Western Health. So we have Dr. Andrew Jeffries, who's a Clinical Services Director, the Perioperative Clinic and Critical Care Services at Western Health. Dr. Kathleen Leach, who's a Senior Clinical Psychologist working at Western Health in the Pain Service, and Kelly McLaughlin, who's one of the Senior Physiotherapists in the Pain Management Service. So thank you to our speakers. And of course, we have Olivia behind the scenes helping us. Just a little bit of an update for everybody about Health Pathways Melbourne. So they do have lots of info on chronic pain. These pathways are written by GP clinical editors with support from local GPs, hospital-based specialists and other subject matter experts. So you can have a look there for specific clinical problems. There's information on management and also how to refer if needs be. So you can put in the search function, looking at pain management and different pain conditions, and you'll come up with the non-cancer pain, the chronic medications, neuropathic pain, and a lot of other pain conditions. If you're not sure and you think something's incorrect, send some feedback. So this is the whole suite of chronic pain pathways. So you can see it's really quite varied. There's the clinical conditions, the medication interventions that you might want to check, and then some resources and referral information, and also some down the bottom here, also the allied health interventions that are really going to be really important in these group of patients. So most of the GPs will have had access to Health Pathways Melbourne. If you haven't, please scan or email the team and they will get you registered so as you can access this great suite of resources. So thanks. So I will now hand over to the team and thank them very much for their support and tonight. Thank you.
Thanks so much, Jo. So my name is Kelly McLaughlin. I'm the Senior Physiotherapist in Pain Management at Western Health, and I'm going to start the session today. I'm just going to review the topics and the learning outcomes that we've got planned for today. In a moment, I'm going to provide an overview of the characteristics of the patients gets referred to Western Health Pain Clinic, so that you can have an improved understanding of the demographic, socioeconomic and clinical characteristics of the patients that are coming in. And hopefully that will help you to understand exactly why a multidisciplinary approach is needed for the complex needs of this group. Then Dr. Jeffries is going to talk about the new Western Health Integrated Pain Service, our new model of care and new referral guidelines. And that's just so that you feel like you understand the model of care and that you feel like you can effectively utilise some of the multidisciplinary services that we provide. Then Dr. Kathleen Leach will be providing some case studies and they'll also provide with Dr. Jeffries a clinical update on chronic low back pain and widespread pain. So we're hoping that those case studies will demonstrate the role of the multidisciplinary team and explain a little bit more about how those services work for patients with chronic pain. And then we'll end the session with a clinical update on deprescribing with Dr. Jeffries, and Dr. Kathleen Leach will also assist with that part of the session. So just thinking about understanding a little bit about the types of patients that are being referred into our clinic. Luckily, we have been involved in a really wonderful project. It's a benchmarking initiative run by the Australian Health Services Research Institute. It's called the Electronic Persistent Pain Outcomes Collaboration, and it's run alongside other outcome registries that you might be familiar with, such as AROC and Peacock. And so now we've got a lot of data that we've collected actually from pain clinics across Australia and New Zealand. And we feel like we have a really good handle on the kinds of patients that we're seeing and also the kinds of services that we think that they need. It's also allowed us to really get a handle on how we're going with clinical effectiveness in the terms of the services that we're providing. So after so many years, we also have a lot of international papers that have been published, and it's been a real journey to collecting all this data, because now we have a very good understanding of the patients that we see. How do we get this information? Well, it requires people completing a referral questionnaire. This has to be done when they come into the centre, and then we will provide them with reviews so that we can actually evaluate what we're doing. This is actually a really big part of our service, and it's now kind of built into the clinic. In some senses, but these days it's very easy for patients to complete it, because what's happened is EPOC is providing a lot of online ways to access the questionnaire. So questionnaires are now sent via SMS and email. We do understand that patients may need assistance or may need a paper questionnaire. We're very happy to provide that. They can even come into our centre and we can help them complete it. But it is really, really important, because we are involved in this benchmarking initiative, that patients complete these questionnaires. For the called patients, the non-English speaking patients, which is about 10% of the people that are referred to us, we know that we can't necessarily give them a questionnaire. We don't have translations of this questionnaire yet, so we would be administering that on a case-by-case basis. But really everyone who comes to see us in our pain clinic, we're really expecting them to complete at least an initial questionnaire. And that means that if they don't complete it, that we will discharge them and we'll send them back to you and let you know that they have not completed that questionnaire. It's just because it's such a vital part of what we do in our clinic. And that's what it looks like. That's the front page there. So because we've been involved in this, we now have really good data on our own clinic, but we have data on really all the clinics in Australia and New Zealand. And so it's allowed us not just to know how we're going in our clinic, but how we are going compared to other clinics across Australia and New Zealand. And it's allowed us to do things like produce really fantastic papers and infographics. So if you're interested in this paper that is summarized in this infographic, just scan the QR code at the bottom of your screen, and that'll take you through to the EPOC website, and that's where all the papers are. So I'd like to feedback a little bit, about the patients that we see and the people that are being referred to us, and really to underline that the main referrer is our GPs. It is you. GP referrals account for 68.5% of the patients that we see. This is a fairly consistent finding. So we do get 6 monthly reporting around EPOC, but what I'm sharing with you now is the results of our mid-year report, which is the last 12 months, more or less. We're just waiting for our annual report to come out. So you can see that you guys are our main referrer, and then of course we have referrals from other specialists and our own hospital. And who are these people that are being referred? What I'm going to describe to you is a cohort of patients who completed the EPOC initial questionnaire. So this is not everyone who got referred to clinic, because some did not complete it, etc. But it's a reasonably good size sample, which is telling us quite a bit about the patients that are coming in, and it is quite consistent in terms of what we see every time we get our reports. What we can say is that the people who are coming in, they are on average in their 50 years old. So we see a lot of 50-year-olds, people in their 50s. 70% are female. They are, mainly female who are coming in. 42% are unemployed due to pain. So they are not working because of their pain problem. 53% have had their pain for more than 5 years. So they're quite long-standing in the pain that they have. And 27% are not born in Australia or New Zealand. Thinking about their clinical characteristics, because we ask them lots of questions about their pain, where the pain is, but also other things like their mood and how they're coping with their day-to-day. And so what we can see is that these patients who come to see us, on average, are really in quite a lot of pain. So 90% of those patients would have at least moderately severe pain, average pain severity. So it's quite a high number. The 92% would have at least moderate pain interference, so moderate to severe. 69% would have at least moderate depression, moderate to severe to extremely severe, and that's measured on the DAS-21. And 50% of those also have moderate or more symptoms of anxiety. 48% have at least moderate symptom severity and stress, and 72% have at least moderate to high pain catastrophizing. Pain catastrophizing is really just worrying thoughts about pain. So it could be worries about damage, the future, or ability to cope. And 83% of people coming in have at least moderate impairment in terms of pain self-efficacy. So they're really not confident to manage their pain in really very many situations. And on average, of the 50 patients of this cohort taking opioid medication, they were using the equivalent of 43 milligrams of morphine every day. We also get a lot of reporting about healthcare utilisation. It's something that we try to reduce through our programs. And what we can see is when you ask people how many times they've seen their GP in the last 12 weeks, the average is 5.1. It's a little bit higher than other services, the average for other services, but these patients are seeing the GP rather a lot. They're also seeing medical specialists, other health professionals such as physio. They are presenting at our emergency departments, and some are even being hospitalised. And this has been looked at through EPOC, through all of the data that they've collected. And a recent paper has come out looking at this and found that patients with the more severe anxiety, stress, pain interference, etc., were more likely to seek help from a GP and to see them multiple times. Also, they've got pre-existing comorbidities, and some of those are mental health conditions. So people are coming in, they have a diagnosed mental health issue. 46.1% of those coming in have something. This is not including every type of mental health issue, but you can see that there's a reasonably high number of people coming in with depression, anxiety, and PTSD as well. And they're also coming in with other chronic health conditions such as hypertension, diabetes, and even respiratory problems they're coming in with. Looking at things like their body mass index, we can see that the mean BMI is 30, so these patients are quite heavy. There are also a fair few in the super obese range as well. So most of these patients, are also overweight and obese. Looking at duration of pain, we can say that the majority of people coming in have had their pain for more than 2 years. So over 70% have had their pain for more than 2 years, and really 52%, so half of what's coming in to see us on average has had their pain for more than 5 years. So it's quite long standing. And if we think of main pain area, which is another thing we record on EPOC, we can see that back pain is the number one reason by a fair margin. It's the number one reason why people are being referred to see us in the pain clinic. Other things that are coming up is things like widespread pain. So we do measure the number of pain areas. And what we can see is that in this cohort, over 30% had more than 7 sites of pain. So their pain is in multiple sites and it's quite widespread. So that's also something that we see a lot of: back pain and widespread pain or fibromyalgia. Just looking at medication use, so we can see that for example, 56% of people coming in this cohort are taking opioids on a regular basis. And you can see the breakdown of all of the types of pain medicines that patients could be using. You can see that medicinal cannabis is not one of those. So we are underdone on that one, but maybe a little bit higher on the opioids compared to other health, other services, other pain services in Australia and New Zealand. Other things that we look at are work status, and we can see that over 60% of people are not working either due to pain or other health conditions. So most people are not working and are not able to work. For those who are working, they are on the whole potentially struggling with the work. So we look at things like work time missed to pain affected work productivity, and overall work impairment. And you can see that these people are in work, but it's not easy because of their pain. There are some difficulties in working. And we also look at things like socioeconomic status, and we can see that we probably are not seeing as many people from the from the areas of least disadvantage. So this chart has been set up according to patient postcode. So most of the people that we're seeing are more in the areas of more disadvantage, not so many in the areas of least disadvantage. Other things that are coming up are things like distance to the pain clinic. So EPOC have looked at this in detail and found that something like 40% of people, only 40% of people who are attending pain clinics live within 10 kilometres, within a close proximity of their pain service, but 10% of people live over 100 kilometres away from their pain service. We've calculated that our patients, patients that attend our pain programs, live on average 30 kilometres away from Sunshine Hospital. So they do tell us that it's sometimes not easy to get to Sunshine Hospital. It's expensive with petrol, expensive with parking, or actually just getting the transport is quite difficult for some people also. And so now that we've gone through that, we can start to get a little picture in our minds of the average patient that comes to see us. And we are encouraged by EPOC to try and think about who is the average person coming in, and to make sure that we're providing the services that they need. And so we can see that on average, the patients that we're seeing at Western Health, they are female, they're in their 50s, they have chronic low back pain, they've had this pain for more than 5 years, they're not working, they have severe depression, they have high pain catastrophizing, they are obese, and they actually have 3 other chronic health conditions that they're trying to manage, and they have severely impaired confidence to manage their pain. And so, so if you can kind of try and imagine what that patient would look like, through the magic of AI, we can actually create an AI-generated patient who has all these characteristics. And so if we do that, this is what they look like. So, but it's useful to think about that. That is kind of the average person that we're seeing in our pain clinic. Now I'm just going to hand over to Dr. Jeffries, who's going to talk a little bit more about the clinic itself and present some data on that.
Thanks, Kelly. So I'll just start with just a little background on myself, as well as being clinical services director. My background is in anaesthesia and pain medicine, so I'm a dual fellow, and have been working in this area for a long time. So a bit of background here as to why we're sort of changing the way we do things. And what we're doing isn't new by any means when you look around Australia and the world. The multidisciplinary model of care has certainly been a standard of care for many decades. What's happened here is that, as happened in many places, the service evolved over time, primarily out of anaesthetics. And so it became very medical focused and medical-led service, to the point now where we're part of the adult specialist clinics. We do work very closely with our allied health team, and we're co-located now, but that's taken a lot of effort. But there has been quite a few bureaucratic hurdles put in our way over the years in terms of really trying to move towards a primarily multidisciplinary flow of these patients. Big part of the problem we've got, of course, is that having that traditional medical one-to-one type care is just not feasible given the volume of demand out there with regard to chronic pain, and that's certainly no news to all you out there. We really only have very limited resources. We hold 1 clinic a week, with 3 to 4 specialists, which averages out to about 3 medical sessions per week, which really is not a lot. So that means we currently have over 1,000, over 1,500 patients on our medical wait list. Some have been sitting there for a long, long time, which has led to patients waiting for many years to see anybody. And you can see in that chart there, looking at the average monthly activity, we're really just sort of, it's a status quo, putting the finger in the dark type situation, where our waiting list is really not changing, given that number of new referrals versus the patients who end up being discharged from the clinic. So the situation now really is, or has been, that the medical resources are insufficient to meet demand. And on the other hand, we do note that our allied health programs are probably, if anything, underutilised. And there's certainly scope there, particularly with the group programs, to get patients in and get things going much more quickly. So that's primarily what we're trying to do. So we will move on to the next slide, Kelly. I didn't think of this, but I think it's very true that by putting someone on a wait list, it's effectively equivalent to telling them that they need to wait before anything will change. So they sit there for a long time expecting some sort of miraculous cure when they come to the clinic, and unfortunately, that sets them up for disappointment. But by expediting first contact, does provide opportunity to address a lot of these issues that Kelly's pointed out in our patient cohort much more quickly, and commence them on a pathway towards change earlier, and thereby hopefully lead them to a situation where they are not suffering longer or unnecessarily. Next slide. Okay, is it back to you, Kelly?
No, I'm going to go to the next slide.
Okay.
Just bear with me, and just ask you to speak to our new model of care.
All right. Okay. So basically, in terms of referral pathways, we do have some triage categories of patients where we think it's reasonable that we see them as a sort of category 1 type situation, where we think that by that early medical intervention is likely to make a difference. And so these sorts of patients broadly would include people with recent onset complex regional pain syndrome, where early intervention may be associated with better outcomes, poorly managed cancer pain in patients with active cancer, and often we get to refer those patients from our palliative care and oncology and symptom management colleagues, looking at perhaps some more advanced interventional sort of techniques. But primarily, that's going to be a very small part of the cohort. The great majority of patients will be can you just go back through the allied health pathway at first, and then once they've completed that pathway, they will determine where they go next. And as Kelly said, patients will need to complete the EPOC form. So we do, as part of that, we run an education session, and that's part of the sort of multidisciplinary approach to their therapy, and that's done online like we're doing at the moment, which really improves the access. Do you want to expand on that, Kelly, or are you happy to move on?
Just to say that, that the feedback that we have had from this informed pain clinic, where people within 90 days they attend a pain education webinar with Dr. Jeffries and then have a phone consultation with a member of the allied health team. We've had really good feedback, so people have gotten a lot out of it, and it's actually enabled people to very quickly decide whether this is actually the direction that they want to go, much faster than, as Dr. Jeffrey said, waiting on a list and waiting to be seen. So even if people exit at that point, it's still it's very timely. It's a timely service that's enabling them to do that without too much waiting.
Yeah, that's a very important point, Kelly. I think we think it's very important to be transparent and honest with people, because there's no doubt that what we have to offer is not going to be for everyone. And so therefore, you're better to get that sorted out earlier rather than later. And there's nothing worse than having a patient sitting on a waiting list for 2 years. They come to see you, and what they're hearing is really not what they want, and it just causes unhappiness all around.
Sorry, Andrew, what percentage of patients are dropping out at that point? Have you got any figures yet?
Kelly might be able to in terms of the patients who just drop out after the first session?
So we've got there's about 30% of people who basically drop out. So they're either not returning the questionnaire, or when they're coming in, and that can be also to see the doctor, as well as coming into the allied health stream, that they are basically not coming back. So I don't know the exact breakdown of those who are not returning their questionnaires, as opposed to those who are just ceasing treatment once it's been offered. But really 30% of people do not engage with the service one way or the other, and that's a very consistent finding over many years of collecting EPOC questionnaires.
Yeah, I think that's true of pretty much everywhere. I mean, some places are a lot more hardline than we are in terms of the terms and conditions of engagement. But yeah, despite all that, that's pretty consistent.
Thank you. I think there's another question here. Sorry, I'm just bringing it up. How do you select if a cold individual be given the questionnaire?
So they've got to have a good level of English. Sometimes we use interpreters, but we are aware that there's limitations to that as well. Yeah, I don't know if you want to say any more about that, Kathleen, but yes, I think we have to accept that there are limitations with this community. I guess one of the options is to get this questionnaire translated, and I think there's been a lot of talk about that in EPOC, but it hasn't quite happened yet. So I don't know if you want to say any more about that, Kathleen.
Just to reassure that if the client is not able to complete the questionnaire because English is not their first language, or because of other cognitive or comprehension issues, then we would bring them in and do an appointment and do the assessment face to face. So they certainly won't miss out because they can't use technology or language. They would be invited in for an assessment and be treated usually one-on-one, as compared to those with good English who can come into the VWIP clinic, the Western Health Informed Pain Clinic, or otherwise attend our group as well. So if they are not able to speak English, they are not disadvantaged, because there's at least 25% of Western Health clients don't speak English as their first language.
Thanks, Kathleen. I've got another question here. Do you know why those 30% don't engage with the service? Has there been any follow-up to find out why, and has the problem resolved, or have they gone privately?
Do you want to talk to that, Dr. Jeffries, or?
Look, I think that's a good question. The answer is no, we haven't at this stage followed that up, but I think that's a good question that would be worth trying to do, because, one thing I can say, it's pretty unlikely that they'd be going privately because of the cost and access issues. I suspect it's basically, somebody really is very pre-contemplative in terms of their state of change, and they're just really focused on a quick medical fix. And we're starting to go down the path of, well, it's much more holistic than that. It's as I said, they're either not ready for that or it's not what they want. We do have people I've found over the time where they do move through those phases of change and come to an understanding that, you really do need to get off that medical merry-go-round and engage in this sort of model to have the best chance of improvement. But yeah, good question. I think it's something we'll put on our to-do list.
Yeah, and I think definitely something that we have found is that, so if GPs do refer and the person doesn't complete the questionnaire, we have had GPs have a chat to the patient and talk a little bit more about the program, and then they've been referred back and they have engaged. So whether the person just didn't quite understand the clinic or didn't think it was worth their time to fill in the questionnaire. But in some cases, the GP has stepped in and provided more education or information, and that seems to have worked really well.
Right. Thanks, Kelly. And so if the patient doesn't engage, the GPs will be notified.
They will, and actually we've actually been doing that via practice email, because we've had feedback that letters didn't arrive, and GPs were not necessarily notified. So we do spend a lot of time really trying to make sure that letter gets back to the GP in a timely manner, because we know that the GP then may decide to talk to the client and see if there's any way that they would be happy to come back. So so that's how we've been doing it, because sometimes we send a fax and it's in a waiting, it's in a queue waiting for all the other faxes to go through in the practice and things like that. So we've had seem to have had really good success with the practice emails.
Right, thanks. It sounds like you're working hard to close the loop. There's just one more. Sorry, I think
I've got that one, Jo. That is, yes, those patients are well and truly aware that they won't be offered an appointment unless they do complete the EPOC questionnaire. So we make it quite clear to them when it's sent out. They're given the option of having a paper copy posted out with a return envelope, or to do it electronically with a QR code, and to fill it out electronically. And Kelly normally has a good chat to them and lets them know what's expected, gives them a follow-up reminder, and then if we still don't receive anything back from them, we'll send a letter through to the GP and let them know, to the referrer, that the referral has been rejected at that stage.
Right, thank you. It sounds like you're working really hard to, try and close the loops and keep everybody engaged. So that's great. Yeah. And I just ask everyone to just put your questions in the Q&A, not the chat too. Thanks.
I'd just like to say one more thing about that. I think what we tell the patients is this is a virtual clinic, so we're not going to see you, and we've got the GP referral, but we need more clinical information. And so the EPOC is actually a clinical tool. It's for the people the clinicians that are going to call the client. Then they have very, very up-to-date clinical information that's going to help them to make that phone consultation more successful. So yes, we do it because we're being benchmarked, but it is actually an invaluable clinical tool for the people working in our department as well.
Okay.
Ellie, enough of me.
So Andrew, shall I go to the next slide?
Yeah, sure. Go to the next slide. Right. So basically, this is just sort of a simple flow chart going to where we are now through to what we're proposing. So you can see basically there, it's a very medical specialist clinic model with the medicos is sort of at the center of the whole process. And so that it creates a huge bottleneck in terms of actually patients getting through even to see the allied health team. And so hence we have this huge waiting list. So what we're proposing is to take the medicos out of the centre and move them as just being one part of the team, which is why, good practice has been for many decades. But as I said, there's been reasons why, despite lots of effort, we haven't been able to do that until now. So we might move on to the next slide, Kelly. So basically a bit complicated, but effectively there is a triage process. As I said, there will be a small minority of patients who will meet the criteria for an urgent sort of medical review, but the great majority would benefit by being placed on the allied health pain team waiting list, where we hope to be able to get them engaged within 90 days. And basically they flow primarily through a group program, or due to factors such as language or other issues, they might have a one-on-one allied health program. With a sort of a beginning, middle, and end, with a plan to eventually being discharged from the program, but with an opportunity for consultation, medical consultation, if it's thought or indicated for various reasons, where there's specific questions which our allied health team would like help with. We meet every week to discuss these sorts of issues. So as you can see, medical is basically off to the right there. It's there, but we hope to get most people streaming through the multidisciplinary program. And the multidisciplinary program, as we've said, does involve medical input as well as part of the pain education, nursing input, physio, psychology, primarily. All right, next slide. So this is just some of the referral guidelines, which have been up on the Western Health internet for a while. And they're effectively just a cut and paste of the statewide guidelines in terms of referral. I won't read it all through there, but basically it does help if patients have some sort of understanding of what they're being referred to. If they're really fixed on a simple medical cure, then that's going to be unlikely, unfortunately, if they're not willing to engage at all in some sort of change of their thinking. As I said, that can just take time, for people to move. So I'll flick through to the next slide. As I said, a couple of examples of what we think are reasonably urgent. So it's the CRPS, if it's a clear indication of that. And in fact, most of those patients will be internal referrals from our orthopaedic and plastic surgical colleagues. They're very clued up on CRPS these days. And as I said, difficult to manage your cancer pains, the two broad groups. It's not to say other people won't be seen urgently, according to the referral, but that's just examples there. So we'll flick through. So perhaps I will let you, or is it Kathleen or Kelly? Kelly?
I'm happy to take this one. So I just in terms of what they would be offered. So if they decide to do a pain program, I think it's just useful to let them know that there are actually options outside of Western Health, and some of you may already be familiar with these options. So when we see these people and we have the webinar and the phone consultation, we're actually listening out and trying to figure out which program we can recommend to them. Some people we feel will really benefit from our virtual Move Do Live program because it's a high intensity program. But there is a less intensive program, the Living Well with Pain program, which is run through Footscray Co-Health. It is free. It just requires a managed care referral for people over 65. And then there's the Mind Spot Pain course. So some of you might already be familiar with these, but I'm just going to quickly summarize what they are now. So if the patient elects to come with us, they'll be doing a virtual program. We did obviously run this face-to-face before COVID, but thanks to COVID, we were not able to, and we developed a telehealth program very much based on what we were already doing. And we've been able to get some very good outcomes with the telehealth format. And because of the things that I talked about, the fact that these patients live a long way away and they often struggle to get into Sunshine Hospital, the feedback we've gotten is that they would prefer it to be telehealth. And because we had the EPOC data telling us how effective our face-to-face program was, we were able to evaluate it against a telehealth program. And actually the results are about the same. And we're probably picking up people who would have just said no way to a face-to-face program because of the intensity. So if people elect to do it, they'll be doing a 4-week program, which is Monday, Wednesdays and Fridays, 9:30 a.m. till 2 p.m. You'll see that that's within school hours because we do have a lot of people who have childcare responsibilities. And so the patient would be logging on to Zoom at 9:30 and doing a live exercise program with physio, and then doing some other individual tailor-made exercises. And then they'd be jumping back on at 11:30 to have workshops with other members of the allied health team, such as psychology and OT, dietitian. And then they'd have a lunch break, and from 1 till 2, they'd be continuing those workshops. Then we would have a 1 and 3 month follow-up, which would also be on Zoom, but it's useful to tell the patient that there will be potentially a face-to-face assessment with maybe some telehealth, and then there will be a face-to-face review afterwards. So we need to see these patients, make sure they're safe to exercise online, and then review them face-to-face afterwards. But most people are very happy with this format. I don't know if some questions have come up that need to be answered now, or you're happy for me to continue. So the next program that we're offering when people come through to our virtual clinic is the Living Well with Pain program. So that was, some of you are maybe familiar with this because it's a primary care initiative. And my understanding is it started in around 2020. So some people may not be aware of this program, but it is still running. It is a less intense program, but it is still multidisciplinary with a physio and a clinical psychologist. It is also 4 weeks long, and you have Tuesday and Thursday sessions from 1 till 4. And as I say, it is free, but you just need to provide a My Aged Care referral with the referral into this program. But if you send the patient to our clinic, we will make that ongoing referral. And that's actually been pretty popular as well. And then there's the completely virtual MindSpot program, which was developed before COVID and has become more popular since. This is run by the federal government. It's a virtual psychology clinic, which has a pain course within it. It is all very self-directed. So patients can elect to have online resources or a workbook. They can elect to have weekly coaching from a pain clinician, or they can elect to actually do it all on their own, and they're evaluated as they go along. This one has also been pretty popular. So patients can self-refer, or you can make that referral. So there's more opportunities than there have ever been for pain management programs in the West, which is a really good thing.
Now, that one's a particularly good one for those who are working, who are not able to attend groups at a specific time and day. So the MindSpot being such open-ended, a lot of flexibility there.
So just a quick question, Kelly, is there any for patients who don't speak English, anything not?
So in terms of groups, my understanding is the Living Well with Pain has some capability to assist with called patients. I think the best thing would be just to make the referral and then just see what response you get. But my understanding is that they have had called groups that have run through there, and I believe they have an on-site interpreter for that and run the group that way. But yes, in our setting, we tend to see our call patients individually because of that reason. The groups are difficult. So just thinking about, okay, well, if you do send a patient, how successful, is this program? Is it kind of worth their while? And these are the results. This is from our mid-year report from last year on how patients are going when they attend our pain clinic. So this is a combination of people who came to pain programs but also had medical input as well. So they may have been on 2 different pathways, but you can see that really most people are getting some benefit. So in this cohort, you had 65% of people who attended our clinic who were significantly less depressed. And so they mark us very hard in EPOC. You have to really have quite a lot of reduction in your depression in order to make that clinically significant. So we can be pretty sure that the patient would notice the improvement, and so would anyone around the patient and the clinicians. 60% are less significantly less disabled, and 57% are less worried about their pain. 54% are more confident to manage their pain in any situation. You can see that in terms of pain relief, we didn't get very much. Only 13% had a significant reduction in their pain severity. But actually quite a few people's average pain severity doesn't actually change that much, which is a bit of a strange thing to try to explain to patients, but the whole pain experience changes, and that's why the pain itself doesn't matter quite as much. But we didn't cure pain, and I guess that's the other message just for clients. We don't cure pain, but we certainly help people have better lives with the pain that they've got. Other things that we can look at is just what the patient is telling us. So the patient impression of change. So we can see that most people who are coming to our clinic are reporting, quite a reason, a general improvement. So in their change overall, but also in their physical function, and not too many are coming out of it very much worse. So they don't have too much to lose. They've probably got everything to gain by getting involved in a program. Also, things that we measure, we do see that healthcare utilisation in general reduces. So the patients are more confident to manage on their own and therefore less reliant on other health services. And that's across the board, and that we do see that as well. But as I was saying, we do have a reasonable number of people who at some point will drop out. They either won't complete the questionnaire or they will attend and then not come back and discontinue by choice. Just other things when you're making the referral, it might be worth just letting the patients know, because we do tell them this as well, that they won't be offered hydrotherapy, massage, acupuncture, or maintenance therapy. People are often looking for this, but we don't offer it in any of these programs. And we tend to encourage them to speak to their GP and to find out what's available, because some of this they may have to fund themselves. So we'll move on to the next section, which is looking at some case studies, in particular chronic low back pain and chronic widespread pain, because this is what we're seeing a lot of in our clinic. So I'll hand over to Dr. Kathleen Leach, who will present the case studies. So I'm just going to reiterate here, you'll see a slide just reminding everyone that back pain is it's really the #1 reason why people are referred. So I'll hand over to you, Kathleen.
Thanks, Kelly. Yeah, I want to tell you a little bit about Bill. I'm just going to call him Bill, but his name's not Bill, who is a 57-year-old male with a very long history of chronic low back pain. He's a panel beater by trade, but is currently not working as a result of his pain. I think the thing for me about Bill was that he, at first I was thinking he's talking the talk, but I'm not sure he's walking the walk. But you'll see from his EPOC results that he had actually quite substantial change across the board. And he certainly reported through his sessions with his psychologist, who wasn't me, by the way, that he was really enjoying the program and learning a lot. He found the concept of pacing was really opened up new doors for him, and he was able to start working on cars again because he was able to do it in a slow and steady way. So he came into the program quite worried about further damage and feeling really frustrated by his pain. Thanks, Kelly. He, as I said, was not working as a result of his pain. He was seeing his GP, but he certainly wasn't a high utilisation of service. He wasn't turning up to emergency department. He was using a range of medications and had a moderate level of pain. Thanks, Kelly. He was extremely severely depressed and quite stressed, but not so, anxious, but not so much stressed, and really did not have much confidence at all about managing his pain, and really catastrophized about his pain in the sense of, this is, it's going to get a lot worse and I'm going to end up in a wheelchair, and there's, it's a terrible and awful thin. Thanks, Kelly. I won't go through his medications, but I'll hold a moment so you can read for yourself that he was on a range of pain medications as well as some Valium. Thanks, Kelly. And you can see before the intervention that he had not just the low back pain, which was the key complaint for him, but also that extended bilaterally in both of his hips and legs. But gratefully, at the end of the intervention, he was complaining more so of the hip and knee pain and a lot less so of the back pain. Thanks, Kelly. As a result of the intervention, you can see that his pain severity and pain interference did go from a moderate to a mild level, so a nice significant decrease in the interference, with the green triangle indicating that it's clinically significant. And having said previously that we don't always get a huge reduction in pain, this was a nice reduction in pain and pain interference. But thanks, next slide, we can see even more significant results from the psychometrics around the depression, the anxiety, and the stress, as well as a massive increase in his confidence, which is a line that goes down rather than up, but having a lot more confidence and no longer catastrophizing about pain. So no longer thinking that his spine is just going to break in a million pieces if he bends down to pick something up. So he reported that he feels a lot more optimistic, and he was able to do more things, like, for example, mowing the lawn. He noticed that he did get a flare-up after mowing the lawn, but he realized that that's what it was. And instead of catastrophizing about it, he implemented his safety plan, his management plan, flare-up management plan, and was able to identify, oh, that was a boom bust. I've done too much and then I wasn't doing enough. So he was able to get back into it and not give up entirely on mowing the lawn, but rather getting back into it and recovering a lot faster from those flare-ups. So the flare-ups were happening less often, they were less intense, and they were recovering a lot faster. Thanks, Kelly. Not a major reduction in the number of medications types that he was taking, but a nice reduction in the daily morphine equivalent, which is an important outcome for our population, because the level of morphine that some of these folks are taking at the beginning of their program is towards the risky end. And as general practitioners, you know how difficult those things are to prescribe over the long term and how risky they are. A significant reduction also in coming to see the general practitioner, which is probably a shame because Bill's a lovely fella and you would have loved having him in your office, but you've also probably had other things that you'd like to do as well. Thanks, Kelly. And you can see that from his perspective that he was feeling a lot improved, a 2 out of a possible 3. He was getting back to doing his do-it-yourself and being a lot more social. He was quite isolated at the beginning of the program. Although he has 2 adult children, his communication was quite poor with them. He was always kind of grumpy and irritable at the beginning, so no one really wanted to be around him. But he really opened up in the group program and was able to really rebuild some relationships with his friends and family. And while he remains on that waiting list for spinal surgery, he was really starting to doubt whether that was going to be necessary for him, which would be a very good outcome if a person is not having to have an expensive surgery and also risky surgery. He did fail to attend his review appointment and consequently was discharged from the pain clinic, which again is a shame for Dr. Jeffries, who doesn't get to see Bill anymore, but it does mean that we can meet more patients who are currently waiting in pain. Thanks, Kelly. So this lovely lady, I'm going to call her Sally because that's not her name, but almost 50-year-old lady, she also had that chronic lower back pain, and quite a typical pattern of low back pain related to the very typical L5-S1, the discs, the protrusion, the canal narrowing. And with all of those medical and technical terms, I think a lot of the patients, that does actually increase their sense of fear and their catastrophization when we talk about these mild flattenings of the S1 nerve origin and so on. For those who don't have high health literacy, that really gives them a lot of fear around there's some serious damage going on there, some really risky things. This is my spine and it's all crushed and falling to pieces. So it is important to be transparent with our clients, but it's not necessarily helpful to talk about these things if they're not given a clear understanding that often these types of disc protrusions and otherwise are quite common in people who don't have pain. This lady, Sally, had stopped working. She previously worked in a warehouse. She'd had to give up her work because she actually couldn't really sit for any length of time. She couldn't drive because it was really quite painful for her to be sitting. And so she was spending a lot of time laying down. And while that was comfortable and pain relieving, it wasn't really helping her to live her life fully and completely. And it really isn't helping the physicality of a body to be laying down like that, as you would well know. But it's hard for someone to understand if something is relieving my pain to believe that that's not actually good for your body, because it feels good. It feels much better. She welcomed actually a place on the program, and one of her goals was to be able to fly over to see her kids in Germany. And she hadn't been, and that was actually extremely distressing. And she spent a lot of time with her psychologist talking about not being able to spend time with her family, her children who lived overseas. Thanks, Kelly. As I already mentioned, she'd given up work as a result of her pain, particularly her inability to drive. She was had a lot of healthcare utilisation in terms of seeing her GP over the 3 months prior, about 3 times each month, and seeing a lot of other professionals, including an inpatient admission and having lots of tests. She had a moderate level of pain. Thanks, Kelly. And interestingly, not as distressed as Bill was. Sally had a moderate level of depression, but not anxious or stressed. She certainly had no confidence that she was going to be able to manage her pain. And why would she have any confidence to be able to manage her pain? Because, the only thing she could see that gave her any relief was lying down. And gratefully, though, she didn't see her pain as really super dangerous or catastrophizing around her pain. Thanks, Kelly. And again, she's taking a range of different medications for her pain. And thanks, Kelly. And similar to Bill, Sally also has a bilateral leg pain and some foot pain as well, which after the program had kind of reduced somewhat, but not a major change in the number of areas of pain. Thanks, Kelly. We did see a significant reduction in that interference and really very little improvement in the pain severity. Similar to what Kelly was saying, that we don't see a lot of change in the pain itself. Thanks, Kelly. Her depression had improved, had gone down, and her self-efficacy had also improved really considerably. And she really did have a sense of confidence about managing her pain and although she hadn't flown to Germany, she was really feeling that that was something she was going to be able to do. Thanks, Kelly. The healthcare utilisation had reduced overall, and she hadn't had any emergency department or inpatient admissions, and she hadn't required any further diagnostic tests. She was reassured by the program that there wasn't more to be done or something seriously wrong with her that needed to be treated by a doctor or an emergency department. Thanks, Kelly. She felt a lot better as a result of the program. Her physical abilities were probably less changed than her sense of kind of overall how she was doing in herself. She's able to now sit on a chair, and she did some lovely work with Kelly and Alice, the psychologist. Together, they did we'll call it a flight simulation, but it actually was a row of chairs in an office with a screen showing the flight takeoff. And I'm not sure if there was a flight attendant. I think, Kelly, was there a flight attendant in attendance?
Yes, we may have pretended that, just so that she got the idea of how she could pace, take the takeoff. And how she could manage the flight, because it was going to be a very long flight.
So really a nice simulation with lots of kind of the sitting on the chair and all the elements of taking a flight and pulling her luggage along and being, having to put it up into the overhead bin and asking for help and asking the flight attendant, for help or for other things, because asking for help is typically quite difficult for folks to do, and they feel embarrassed about their pain, and so they don't ask for help. So it was a really, really great way of helping her build her confidence. She's using lots and lots of strategies. Thanks, Kelly. The research shows that the more strategies you have, the more effective a pain management program will be, and she had tons that she was using at the end of the program. Now, Kelly's also provided us with the Western Health versus All Services data here on the, again, just reiterating the common widespread pain or fibromyalgia, very common in our clinic. And so we'll talk about this lovely lady, I'll call her Jenny, just making this up on the spot, I better write that down, Jenny. Much younger than our low back pain clients are our fibromyalgia or widespread pain clients. They do tend to have this pattern. Frequently, it comes around a lot earlier, and this is very typical. In addition to the widespread pain, Jenny also had a long-term history of migraines for the last years, and then this pain just seemed to have developed across her a number of parts of her body. She'd quit her job, also working in warehousing, and as a result had financial stress. She has small children at home, and her first language is not English. She can read simple English, but really we kind of wanted to work quite closely alongside her to be able to translate the information. And she also accepted the group-based program. And I think it did her the world of good to see other people in pain. She'd become quite isolated. Thanks, Kelly. And for her, she needed to borrow an iPad. She did not have the technology. And in our program, we're able to provide an iPad with a dongle so that they have internet access without having to pay for that. And we can see that before the program, she was seeing her GP frequently, as well as other health professionals. Thanks, Kelly. That she was severely depressed, anxious, and stressed, had no self-confidence, and really had a lot of catastrophic thoughts about her pain. Thanks, Kelly. She was on a range of medications. some for her migraine, as well as for her mood, as well as her pain. Thanks, Kelly. And very typical that's thanks for summarising 28 sites of pain, severe pain in particular in the hands, plus fatigue and difficulty sleeping. And at the end of the program, the number of sites had reduced to 20. It's still a lot of pain and still wide spread. The fatigue had improved, as had her mood and her sleep. But the intensity of the pain hadn't changed that much. Thanks, Kelly. And you can see there that both the pain intensity, severity, and interference at the 3-month follow-up at the end of the program was somewhat changed. At least the interference had gone down and continued to go down at the after the end of the group, all the way through to the 3-month follow-up. She was continuing to have some one-on-one sessions after the group-based program. Thanks, Kelly. And very gratefully, her mood was now in the normal range. She remained anxious, but her stress had reduced, despite the fact that she still had many of the same stressors in terms of financial concerns and raising her children. She wasn't feeling as stressed. She was using strategies to manage. Her catastrophizing thoughts had been reduced, and her confidence, although it had that kind of V shape and kind of rebounded a little bit, it was still a significant improvement. Thanks, Kelly. And yes, go ahead, Kelly.
I was just going to say,
Jenny.
I've got a bit of feedback. Yes, just was going to say, should we skip the next case study? Because I'm just looking at the time. I just wanted to give you guys some time for the deprescribing. Would that be okay?
Yeah. And the last case study, Susie, was actually a beautiful case study, but I don't think we need to hear our very best work. But she was an amazing lady who had a lot of psychosocial stresses. Her family, both her son and her husband, had schizophrenia, and she was their main carer. So she had a lot of stress, but she was an incredibly robust person and had a lot of psychological skills. So she came into the program and was like, oh my God, I've totally forgotten that I'm supposed to do self-care. I know what to do. And then she was it reactivated a whole bunch of self-care that she had learned through becoming the carer of her husband and son. So yeah, let's move on.
So I'm going to...
Yeah, while you're changing up this, I'll just say that yes, Jenny was able to go back to India to see her family, which is fantastic.
So just bear with me. I'm going to share my screen again.
And we'll hand over to Andrew for deprescribing.
So I'm just going to share my screen again. Over to you, Andrew.
Right. Can you put it on presenter view on the full screen, Kelly? That's better, yeah. Look, I'll just quickly whiz through. We've sort of presented our own evidence, but obviously there's a lot of evidence out there around the efficacy of this approach to managing chronic pain. Quite a few systematic reviews, type papers and so forth. They all say similar things in that, yes, there is an effect. It's maybe not that great, but it's certainly better than doing nothing and, compared to the alternatives. These are the hardest of the patient cohort. It's a very difficult condition to manage. So this is just but one of many that are out there. And, basically says, look, it's worth doing, and certainly it has the potential for improvement with very little in the way of downside. The other thing is, of course, there's the heterogeneity of the various studies that are pulled into these systematic reviews is a problem. There are lots of different approaches and so forth out there. Let's go to the next slide. The other thing to say is that the great majority of patients that are collected in these sorts of studies are primarily sort of widespread body pain, fibromyalgia, and chronic back pain. This is another systematic review, particularly focusing on fibromyalgia, and basically concluded that these programs are effective, particularly when they include those highlighted areas as what we do: pain education, some form of a rehabilitation exercise program, and a cognitive behavioural approach addressing the individual's fears and false beliefs and emotional management. So we'll move on to the next slide. So this paper actually had quite a few different studies, and I have to say some of them included treatments I consider fairly fringe. The paper published by Seral probably would be the most conventional approach, very similar to what we do. They actually had two different intervention groups, one of over a period of 2 weeks and the other over a period of 10 weeks, and did show quite a good improvement in both groups in terms of the measure such as the fibromyalgia impact questionnaire, which you can easily look up online what that includes, with a post-intervention decrease of, I think, 17 points, with 8 being considered clinically significant. So they were able to show pretty good benefit in the program that they had. Next slide. So just quickly through this, this is his actual paper. Go to the next slide. That was their protocol. So they actually studied almost 90 patients and divided them into normal treatment, pretty much doing nothing, versus a short-term 2-week program and a longer-term program. And interestingly, the two programs had very similar outcomes there. The longer program had some benefits in terms of improved quality of sleep, but really overall, for the effort involved, you'd probably say you'd go with a shorter, more condensed program. Next slide. Just showing that the patient groups in table 1, there's no significant difference between them. Next slide. And these were their outcomes, particularly if you're looking at the various domains. They measured pain and sleep, and the fibromyalgia impact questionnaire is down in the middle there. Most things had quite a significant improvement compared to the control, and indeed they also had clinically significant. Obviously, it's a difference. A pain score reduction of 1 point out of 10 could be statistically significant, but you question whether it would be actually clinically significant. So just, one particular study, this is from Switzerland, which did show this sort of program engaging patients with fibromyalgia can be beneficial. Next slide. With regard to chronic low back pain, again, the message is pretty similar. This is a recent Cochrane systematic review concluding that generally they're more effective than usual care, and in terms of decreasing disability in particular in people with chronic low back pain, and recommend that referral as opposed to usual care is likely to confer a benefit in terms of reduced pain, in particular reduced disability that does endure beyond 1 year. One of the good things about
attention, please. Visiting hours will end in 10 minutes. Your cooperation in meeting.
One of the good things about these sorts of studies is actually quite a few of them do follow the patients up for more than the sort of traditional 6 to 12 weeks, which some of the earlier, particularly pharmaceutical studies did, and really didn't tell you much about long-term outcomes. Next slide, thanks. So just a little taste of all the evidence out there that does point towards the benefit of these programs. And I think one of the great things about the EPOC registry is that we will expect to see quite a lot more outcome data coming out of that, and actually focusing on the different cohorts, and pretty rigorous data, as Kelly said, in terms of really focusing on clinical significance, not just statistical significance. So I think, and what we're seeing so far does point to the benefit that people can achieve by participation. Not universal, as we've demonstrated, but certainly most people do get some benefit for low cost. Okay, next slide. A little bit de-prescribing. Here we're really talking about opioids. It's no news to anybody that in recent years, we've become much more aware that the limited role that chronic opioid use has in chronic pain, and indeed the huge amount of harm that's being created with the opioid epidemic. There's quite good dramatised documentaries on the streamers around the impact that the Sackler family had, particularly in this regard. And unfortunately, now the switch to fentanyl in the US in particular, which is causing devastation in terms of deaths, particularly. So yes, this is a local study demonstrating that for acute back pain or neck pain, let alone chronic, that opioids have a fairly limited role. Next slide. And a paper from JAMA again, looking at patients with chronic back pain or hip or knee osteoarthritis pain, and concluding that treatment with opioids was not superior to treatment with non-opioid medications over 12 months. Look, all these studies are pooled data, and that's not to say that some patients might not get some benefit from a modest use of opioids and not too troubled by side effects. So in all these sorts of evidence, it's about bringing that evidence back to you in front of the patient in front of you and trying to come up with some sort of rational plan. But overall, the message that I give to patients is, look, put aside all the issues around misuse and risks associated with opioids. The fundamental issue is that most people, it doesn't really work that well and is associated with pretty nasty side effects. Next slide. In terms of deprescribing, look, again, I'm sure all of you involved in general practice would be quite familiar with the principles involved in deprescribing. This is a recent paper from the MGAA giving some advice and guidelines. This next slide, just focusing on what the recommendations are. This next slide, Kelly. Basically, back one. I think basically the recommendations revolve around the fact that, look, it's a good idea to do, particularly if patients are not getting any reasonable benefit, troubled by side effects, and particularly at the higher doses. I think that's the message. If you're telling me that you're taking these drugs and you're still getting lots of pain, then why are you taking it? That's sort of the simplistic message. And obviously it's a lot harder than that, and trying to get people to engage in a change process. And I'm sure all of you are familiar with the principles of motivational interviewing and so forth in terms of trying to get people to move from their current position. I won't read through all those. You can look that up yourself if you haven't seen it already. Next slide. Another quite nice table, which you may have seen, which summarises, if you're going to embark on a deprescribing or a taper of opioids, sort of recommendations around how you might do it. Again, they say things like, when would you consider doing this? Again, no meaningful improvement in pain or function. The pain's gone away, obviously. The adverse or intolerable side effects, where you assess that the risk of harm outweighs the potential benefits, and in particular if there's signs of aberrant behaviour. I won't go through that in any detail. Again, the references there, you can look it up yourself if you haven't seen it already. Next slide. On the other side, just a note of caution. There's quite a lot of data coming out from the States that mismanaged tapering or deprescribing is itself associated with potentially significant harm. This is a paper published in the last couple of years from the New England Journal, which actually followed patients where a number of the sort of dodgy pill mill type clinics were suddenly shut down, and thousands of patients were suddenly left without a prescriber, and what happened to them. And so you can see that they found that the risk of problems in that situation was much higher than perhaps it would have been if you'd continued on and then embarked on a more rational, time-based tapering program. So odds ratios, 1.5 to 2 times in terms of diverting to illicit use. The risk of mental health crises were significantly increased. Overdose events through illicit use, and particularly if patients were on long-term opioids, the risk of overdose or suicide was nearly 7 times those that compared to those that weren't forced to discontinue all of a sudden. not saying that this is not saying that tapering or weaning is not a good idea. It's just taking a very hard line, pull the rug out from under people is potentially associated with harm. Okay, next slide. And again, from pain itself, another paper, separate paper, coming to the same conclusion and highlighted there by saying discontinuation, whether abrupt or with a dose reduction, does potentially increase the risk of suicide compared to those the stable or increased dose. On the other hand, you're effectively replacing one risk with another, but by discontinuation of dose reduction, it does reduce the risk of overdose, which is often accidental compared to those with a stable or increasing dose. So it's a good idea to discontinue if only for that reason, but it needs to be done rationally and with compassion. Patients with abrupt discontinuation are much more likely to overdose on heroin or other illicit drugs. Again, a note of caution. Next slide. All right, so we might leave it at that. We've got 3 minutes left for Q&A. I hope that's given you some information on what our philosophy and in terms of trying to help out these people and what sort of services we might be able to offer.
Kelly, what is the wait time now for our Western Health VWIP clinic? What's the wait time?
Oh, really, 12 weeks. And some people are going to get in quicker, just depending on whether there's a little bit of space in some of the clinics, because they're running every 6 to 8 weeks, and we try and get as many people into the clinics as we can.
And I've got a question. So I noticed with a couple of the case studies, there was some reduction in their medication use. Was that after, did they see you in clinic, Andrew, or one of the other clinicians, or did those patients go back to their GP and the GP was able to sort of wind them back, or were the patients just reducing it themselves? Which
look at all of the above. I think this is probably somewhere there's scope for improvement. They're actually actively using the opportunity they've got to taper down, and this is where those in general practice colleagues can be helpful in that regard, and obviously that requires a degree of communication. I think the patients on the high, certainly above the 100 morphine equivalents per day. I mean, I think that's a very nice concrete goal to start with. Say, I want you to get below 100 because it just makes life easier for everyone. If nothing else, it makes sense clinically. You don't have to have a permit to prescribe at that sort of level. People are much more comfortable if you're well below that sort of level as an initial goal, with it perhaps trying to get down further. And it's likely that a lot of people, these sort of legacy patients who have ended up on these high doses may well end up on some more moderate doses long term. But any sort of reduction is beneficial, I think.
Thank you. Got another question. Besides gradual tapering of opioid analgesia, do you have any other general management suggestions or resources for GPs?
In terms of resources, there's a lot out there. I didn't get a chance to put up the slide. You guys, I see you've got a lot of resources there. There's a lot of stuff out there. The Australian APS newsletter includes, the Australian Pain Society includes lots of resources which we can make available. New South Wales has got some good online stuff that can give you advice around the tapering. That NPS medicine-wise chart pretty much summarises what they all say in terms of recommended, how fast to go and maybe give a bit of clonidine if they're getting a bit of withdrawal and things like that. And it's basic motivational interviewing principles, in terms of how you would manage any sort of dependent person.
Thanks, Andrew. And I think those resources we can put in the email that'll come out with the links to everything.
We can include that for you, yeah.
Yeah. Another question. How does the GP communicate with the pain clinic whilst co-managing the patient if there was an issue they wanted to discuss with the team?
In terms of working with the allied health team, myself and Kelly have got fairly open channels of communication with the GPs. So yeah, if we wouldn't necessarily reach out to the GP unless there was an issue, and if there was, we would. But at the end of the program and at the end of the 4 weeks, we send an interim summary, and then again at discharge we send a summary. So our contact details are on that. Dr. Jeffrey?
Look, I think to be honest, it's the current situation is poor in terms of the ability to communicate both ways. And it's something which I personally think we need to work on with our GP colleagues. You know, if a patient has a sort of tapering plan and people want to call up for make contact for advice, then I think it's not easy at the moment, and that's something which I'm very keen to improve. You know, look, it's no secret that the systems that we have here are poor in terms of letters and communication out into primary care in general. There's a lot of problems in the systems that we have. And when I dictate letters for every patient that I see, but I don't think they all get out there. I'm sure they don't, which is disappointing. So anyway, look, I'll take that on board, and I think that's something which we definitely need to improve.
Thanks, Andrew. Any other questions? Anybody got anything else they'd like to ask the team while they've got them? No? Okay, well, time has just ticked by. I'd like to thank Andrew, Kathleen and Kelly for a fantastic session. I think it was really quite informative, and we've all learned a lot and got some ideas about the sort of patients that we're all seeing, no doubt, that would benefit from a program like this. So I think you know, it's going to be really helpful, and then managing these patients ongoing with the team-based approach. So I think that's really, really helpful, something like the GPs like to do. So so we'll be keen to see how it goes, and then to be able to, you know, hopefully improve in our communication going out. Always in GP liaison land, we're keen to hear if people are having difficulties. We know it's challenging, so it's challenging for the clinicians and it's challenging for the GPs receiving, you know, or not getting the information. So please contact us.
This is the first step, hopefully, of improving the situation. So thanks for those that attended, and look forward to further engagement.
All right. All right, thank you very much. And everybody will receive the email from Olivia with links to the slides and the resources. And please, please, please provide us feedback. We would love to know what you want to hear from us at the hospital, what other topics that you think will be helpful in your work, where you're having difficulties, so as we can tailor a program that's going to be helpful for everybody. So thank you. And thanks for Olivia at the PHN for her support tonight. So been very good, very good. I haven't had to deal with the technology, which meant everything has stayed online and I haven't crashed it. So thank you. All right, we'll see everyone again.